take one group each, and then you can email it to me. Anyway, I will send that message on this WhatsApp, and then she can forward it to you. So I'm just going to show you shoulder flexors as a sample of how we should do strengthening. All right. Okay. So now we are going to take shoulder flexors. We take shoulder flexors at grade 0, so that you can see grade 0 to grade 5 strengthening for all the muscles that we can do. Now, when it is grade 0, how do we define grade 0? It is not even a flicker of contraction. And logically, somebody is at grade 0, we see position for length of patient muscle so weak that it's not going to be able to work against gravity. And therefore, patient's position cannot be such that the patient has to contract against gravity. And therefore, I'm going to make my patient go in sideline, because in sideline we check for grade 2, because there is not going to be influence of any gravity here, and therefore this position patient in sideline. I'm going to show you shoulder flexors. So shoulder flexors at grade 1 will be when I ask her to do something, there will be some flicker in her muscle, and therefore I need to palpate. Anterior axillary fold is where I can palpate for her shoulder flexors. Now, using our knowledge of levers, I'm going to flex her elbow so that I'm reducing her weight arm, and therefore the effort arm, effort arm doesn't reduce, the effort that patient has to put in is less. Always make sure now that when you are going to start strengthening, we are going to make sure that it is easy for the patient to give some contraction to begin with. And as patient strength improves, then using that overload principle that we learned in our theory, we are going to start making it more and more difficult for the patient. So when I want to start initiating the contraction, because grade 0 is no contraction, I'm going to put her in sideline, so there is no effect of gravity. On top of that, I'm going to flex her elbow, so the leverage or the load arm is less. And then I have to give her stroking on the muscle that I want the contraction to be elicited. Usually the stroking is done from distal to proximal end. So I'm not going to do it in this manner, but I will do it from distal to proximal. Why am I doing this? Because that's where the tendons of all the flexors are situated. Okay, so I'm going to do it from her forearm, from the anterior aspect of her arm going into the anterior axillary fold. What am I trying to do here? This is the sensory stimulus that I'm going to give to the patient. So think of your stretch reflex R. When I'm doing this, I'm trying to send the sensory input from the afferent, which will synapse in anterior horn cell, first your posterior horn cell, from there anterior horn cell, and then the motor or the input will be, output will be sent to efferent to the effector organ, that is your muscle, and then we will get the contraction. So I'm just trying to stimulate stretch reflex arc here, where sensory stimulus will go and then synapse in spinal cord, interneuron, and then the information will come on the motor neuron side. The axon of the motor neuron or anterior horn cell will then work as efferent, and this stimulus will then be relayed to the effector organ, that is nothing but your muscles, and there might be some contraction. I'm not saying it is going to happen on the first attempt or first day. It might take few days to show the response, but we have to keep working at it so that it doesn't happen that we are not doing anything, we are waiting for the God to work and give some innervation to the muscle. We have to start putting these demands so that we will start getting the contraction if possible. Okay, and that I'm going to combine with the passive movement. So I'm going to do stroking, or I can do tapping. It has to be brisk, Along with that, I am going to do passive range of motion at shoulder. Why am I doing passive range of motion? Now, passive range of motion does not increase the strength. Remember that. But I'm sure you remember what you have studied in your first year 2 months back. That passive range of motion or these exercises are going to help preserve the memory of the movement, and it's not going to allow the contractures or the tightnesses to set in. Because if that's happening, even though the muscle is getting some strength, this will be an obstacle. The contracture in the muscle might prove to be an obstacle for patient to do the movement. And therefore, to retain the memory and to make sure that the joint range of motion is not getting limited, we are going to do passive range of motion. So when I'm trying to give a sensory stimulus, if I do the movement, memory is going to get triggered, and maybe that also can help to get the contraction in the affected muscle. So this is for grade 0 to grade 1, that is going from grade 0 to going for grade 1. What else can be done? Do you all remember your suspension along with sensory stimulation and passive range of motion happening together? We can also give auxiliary suspension for the patient to begin with, because at least when we start, it's going to do some movement. Okay. So again, to help retain the memory of the movement, ideally for strengthening, so we give modified axial suspension that we can give when there is some contraction. Now, after doing these 2-3 techniques, if we feel, or on patient's own also, because of some recovery, spontaneous recovery, patient shows that there is some contraction or there is flicker of contraction, I can start first for grade 1 going to grade 2. During that time, I can give her modified axial suspension. So now she starts going in movement which is partially against gravity. Correct? Simple harmonic motion. You recall your suspension that has been done with you all in the first year. So patient will still be in sideline position because we have to strengthen flexors, the axis or the fulcrum of your suspension is going to be posterior to her shoulder, and then we can start the movement. She will complete the movement in the range that is possible to her. Remaining motion will be done with the suspension. So that is how we are going to help her by modified axial suspension to perform the movement, and part of it is going to be against gravity. Correct? Because of the R. Please recall that. Then the other techniques we will have to continue with her with choking or tapping, that is sensory stimulation, and us doing it, because now she's able to just show a flicker of contraction. She's still not able to complete the movement. So we will still be doing the 2-3 techniques that we've done first. We will add the modified axial suspension. This is something else I will show you. There is a table called as re-education table. We don't have that, not many people have it, but it used to be there in the clinic in the olden days. So it is nothing but a platform, a wooden platform, and it has 4 collapsible legs, 2 on this side, 2 on this side. So now if I want to position my table like this, I'm going to have these 2 legs open. These 2 legs will be folded. So I can put it across patient's arm like this, and I will allow her to perform the movement at shoulder in the direction of flexion. So this is going towards gravity. Gravity will help for weak muscles. So in this situation, we can get help on gravity to allow her to perform the movement. I'm still keeping her elbow flexed, but if you feel that it's okay to extend the elbow and she will be able to slide down, we can do this movement also. Because because this is again told gravity, the re-education table is being used to help the movement of shoulder flexion at the shoulder. This is another technique that can be used. Okay, so doing these 2-3 techniques, also remember that you haven't done it, I guess, because college hasn't started. Stimulation has been done with them.
Stimulation आम्ही त्यांना दाखवलेला आहे मोठं points.
Okay. So electrical stimulation is something that can also be added, from grade 0 to grade 2. Again, I want to make sure that you are aware that stimulation is not really going to help in building up the strength. But like passive range of motion, we do electrical stimulation to keep the contractile properties of your muscles intact, so they do not get fibrosed. So your passive range of motion, electrical stimulation should be done from beginning. I cannot isolate electrical therapy and exercise therapy for you all like that. But therefore, when we are doing strengthening, these two techniques can be used, but you have to remember that they are not going to help strengthen the muscle. They are just to make sure that your muscular contractile properties, physiological contractile properties of the muscle are maintained. So that when strength starts getting built up, patient finds it easy to perform the movement. Now at grade 2, what happens? What is the definition of grade 2? Full range of motion by voluntary effort of the patient in gravity eliminated plane. So when patient starts doing the activity on his own, it could be in gravity eliminated plane also. That's the time he does not need passive range of motion and electrical stimulation, because now patient is able to do contraction of his muscles on his own. That's the time we withdraw electrical stimulation and passive range of motion from our treatment regime. Remember that, this is just for your information. Okay. Now, one more thing that can be done from grade 1 to grade 2 is what? Active assisted exercise. Because remember now patient is able to show some flicker of contraction. So what I can do is, I can keep the elbow against legs and I can ask her to take the arm in front as much as she can with her own voluntary effort. Try and take it in front. I can maybe combine it with the sensory stimulus I am doing. Let her complete as much as she can. Remaining, I will do it, because that's becoming active assisted exercises. That also you have done it in first year, right? So I can continue with sensory stimulation, passive range of motion. I can ask the patient to initiate the movement and let her do as much as she can. Remaining, I can complete. I keep the elbow flexed even now because I want to have her reduce leverage when she's working or when she's doing the exercises, because the muscle is still weak to be made to work with larger leverage. All right. Then I showed you we can use pillows, or that is actually for your re-education table, and they need to be inclined downward so that the movement is in the downward direction, which is toward gravity. So in this movement or in this position, gravity is helping the flexion. Okay. We can also give modified axial when it is 1. Going from grade 1 to grade 2, we can use a modified axial where the fulcrum is positioned posterior to the shoulder so that it resists the shoulder flexion. Is this clear up to now? Yes, ma'am.
Yes.
Yes, ma'am. So now by doing
Yes,
all
ma'am.
for 1 week, 2 weeks, sometimes it could be even longer because each patient is different. We cannot predict how many weeks he or she will need. But now by doing all this, we have got the patient at grade 2. Sometimes remember the patient may not come to us when there is grade 0. Grade could be 3, it's not 5, it's 3 or it's 2. So whichever is the muscle grade, from that grade onwards, we have to do the strengthening. And therefore, to establish the grade, you will have to do your muscle strength testing. That is what we've already done. Correct? So now, when it is grade 2, patient is going to be able to do complete range of motion in gravity eliminated plane on her own or voluntarily. So this is the time I can have her do active exercises as one of the treatment regime. I can resist her manually, take it in front. I will give her resistance at wrist. If I feel she is not able to tolerate resistance at wrist, I will hold it and I will give it to her at the arm, take it in front. Again, I am trying to use my knowledge of levers here and I am giving her or I am making her work through a shorter leverage to begin with. Take it in front, take it in front. Once she is able to do this without any problem with my manual resistance, I might again want to check if she is able to work to the longer leverage with the same resistance, manual resistance. Take it now. Let's try. And when I feel she is able to take it, I will make her work through longer leverage. One. Can you come close? I want to get her closer to me so that I don't end up bending over because it's going to hurt my back also. Whenever you are treating your patients, you have to think of patients, you have to think of yourself also so that you do not get hurt during the process. Okay, so this is one. I will give a manual resistance, take it in front, take it in front. Yes, I have to make sure that the resistance is not too much, otherwise she will perform movement with jerk and it's not a smooth coordinated movement. So that tells me that my resistance is more. What are the other methods of giving the resistance? Okay. I will give her the lowest dumbbell and I will ask her to perform the flexion. Okay, so I can use 3 weights in the terms of dumbbells. I can tie first weight. Again, every time I need not tie it at wrist. I can tie it here also because then what's happening? My point of application of weight is closer, but I can keep the arm extended. So I'm playing around with the load arm. Okay. Now the point of application of weight is going to be the weight, this weight, the weight that I have applied, and the center point where all this weight is concentrated. So it's going to be slightly distal to the elbow, but it is not going to be at this. So my point of application of weight, I have shifted it closer from shoulder, and therefore the effort also is less. When if I were to tie this at the wrist, she will have to exert more effort. So I expect more contraction from her muscle. If she is ready for that, absolutely go ahead and tie this here. But in the initial period when she's still weak, I do not want to utilize the full lever. Okay. Take it in front. Yes. Good. I might once in a while, if I feel she is dropping down, I have to hold her, and that is an indication that the weight that I have tied is higher. So I will have to reduce. So this is going to be trial and error. Every time when you are giving her overload, you will have to see what is the quality of the movement and then decide how do you want to do it. You can do it with her elbow flex also. Now this is coming in her way. I might want to shift it proximal so she can flex her elbow and then do the movement. So again, I am increasing the weight, but I am not increasing the leverage. So you have both these parameters at your end to decide how you want to go ahead with the strengthening. You can increase weight, that is intensity we saw in our theory lectures when we had. You can also increase the load arm and you can increase load arm as well as weight. So you have these 3 ways how to increase the intensity. It's going to be your discretion, of course, based on patient's response. So there is no hard and fast rule that I need to keep it like this and keep it like that. You have to see that patient's quality of the movement is not getting jeopardized. And then go ahead and use your knowledge of fevers to say where you want to tie this. I can even tie it here. After forearm, after arm, I can tie it at the forearm and then I can tie it at wrist. So you have all these three options open for you. Okay, so the other thing we can use is Hera bands. We saw that these are elastic bands and they are based on the principle of elasticity and Hooke's law. So I'm going to have the band around her. I'm holding it for now, but you can have a pole or a grid and a bed there which you are going to use always for any strengthening. So you always have, different height, different bars, and you can tie the TheraBand to that. So I will hold it for now and I will ask her to take her arm in front. Take it. Okay, take it now. This is higher for her. So I have to change the resistance of the band. I don't have right now, but you saw what happened. Take it. This is too high for her because she's flexing her elbow. So I'm not getting what I want. And therefore, then I need to change the color of the TheraBand or the company. Each company has a different resistance and they have different color code. Whenever we buy that, they provide us the lowest